Second person is Dr. Rahul, who is going to present advances publication in HPV surgery. Rahul is from SGPGI, assistant professor.
So good afternoon. First of all, I want to thank the organizers for allowing me to present this. I will be presenting landmark publications in last 1 year in hepatopancreaticobiliary. So there were more than 200 RCTs and around 50 meta-analysis in last 1 year in this field, but I've selected few of them. First of all, in terms of biliary tract, the long-term outcomes and exploratory analysis of the randomized phase 3 BILCAP study, which was published in 2019, and then followed by this long-term outcome, which was published in Journal of Clinical Oncology with an impact factor of 44. It was a multi-center prospective study from UK, 44 centers were involved. It compared, the hypothesis was that adjuvant capecitabine improved overall survival in biliary tract cancer. And the oral capecitabine which was used was 1250 milligram per meter square from day 1 to 14 on a 3-weekly cycle for 8 cycles in all operated biliary tract cancers. The inclusion criteria was age greater than 18 years, ECOG less than equal to 2, no organ failures, and proven cholangiocarcinoma or muscle invasive GBC. The surgery was with curative intent and macroscopically negative margins were included. The exclusion criteria included pancreatic and ampullary cancers in patients who were thought to be biliary tract cancers or lower bile duct cancers and turned out to be pancreatic or ampullary cancers, and no patient with previous neoadjuvant therapy was included. The primary outcome was overall survival, while the secondary outcomes of long-term analysis was per protocol analysis of outcomes and recurrence-free survival. So the chemotherapy was started from 18 to 16 weeks, and the cholangiocarcinoma was included in the study after 2008. There was sample size which was calculated as per power was 360 patients and 270 events. So the recruitment was done from 2006 to 2014. 447 patients were included, 223 in the adjuvant therapy arm and 224 in the observation arm, which finally the per protocol analysis included 210 versus 220 patients. So the maximum number of patients were from distal cholangiocarcinoma and hilar cholangiocarcinoma. Muscle invasive GBC was around 20% in each group. The R0 resection was 60% in each group. And the median follow-up, while the other parameters, the basic parameters were similar in the two groups, median follow-up was for 106 months, and there were 272 deaths due to the biliary tract cancer, and that gave adequate power to the study. On the intention to treat analysis, the median overall survival was clearly better in capecitabine group, and even the median recurrence-free survival was also clearly better in the capecitabine group in both the intention to treat analysis and the per protocol analysis. The median overall survival was 49 months versus 36 months in intention to treat analysis, while in per protocol analysis it was 52 months versus 36 months with a hazard ratio of less than or around 0.8 in all the groups. So the maximum chances of recurrence which they discovered was within 24 months in both the groups. So they insisted on giving the adjuvant therapy early, and it should be completed. However, in this trial, only 55% could complete the adjuvant therapy. There was significantly poor survival in R1 resection in patients with positive nodes and poorly differentiated tumors. The local recurrence was more common in patients with R1 resection, which was obvious, and the better survival was recorded in females. So this was the largest prospective RCT, adequately powered in a multi-center study to be so that it can be generalized better in the public. But the limitations were there, that the heterogeneity of biliary tract cancers was there. It included all the gallbladder cancers, the hilar cholangiocarcinoma, distal cholangiocarcinoma. So it is difficult to generalize into all. The second thing was the recruitment was over 10 years, so there were changes in regimens of chemotherapy. But this trial included only capecitabine as the adjuvant therapy. Now new combination chemotherapy is well established as a part of adjuvant therapy now. But in conclusion, we can say that capecitabine should be included as part of adjuvant therapy in bile duct cancer according to this study, and this was based on previous 7 RCTs, like 7 RCTs which used gemcitabine based chemotherapy in biliary tract cancers, and there was a meta-analysis in 2012 which suggested that adjuvant therapy was beneficial only in R1 and node positive cancers. Recently there was a study published from GB Pant, there was RCT, which showed no benefit of adjuvant therapy after R0 resection. But all these trials included gemcitabine and capecitabine or gemcitabine alone as the chemotherapy regimen, while BILCAP established that capecitabine is useful and should be included as part of adjuvant therapy in biliary tract cancers. Coming to the liver, there was a randomized control trial which was published this year in International Journal of Surgery, which has an impact factor of 13.4. It compared the laparoscopic anatomical versus non-anatomical hepatectomy in treatment of hepatocellular carcinomas. So it was published from China, and the hypothesis was that anatomical resection is superior to non-anatomical resection, which was based on 2 previous meta-analyses and 1 RCT in open surgery. And the recruitment occurred from March 2013 to January 2018. 385 patients were included. The inclusion criteria were 18 to 75 years of age, good general condition, child A or B status, ICG retention at 15 minutes less than 10%. The FLR should be more than 40%. There has to be a single tumor and no intra or extrahepatic metastasis and no vascular invasion as such. The exclusion criteria most important was presence of portal hypertension, either clinical or on endoscopy or on imaging. And apart from that, there need not be any additional organ resection apart from cholecystectomy. The laparoscopic anatomical resection ranged from subsegmenectomy to hemihepatectomy, and non-anatomical resection, the margins were always confirmed by the frozen section. There was 1:1 randomization. The primary endpoints were 5-year disease-free survival, while the secondary endpoints were operating time, blood loss, transfusion, requirement of transfusion, the requirement of conversion, complications, recurrence patterns, and the 1-year, 3-year, and 5-year overall survival, and 1-year and 3-year disease-free survival. The median follow-up was 72 months. The target population was 368 as per the calculations, and they included 400 patients, out of which 385 were randomized finally, and 192 and 193 patients were in each group. The baseline characteristics were similar. The average diameter of the tumor was 4 centimeters. The demographic profile and patient condition, tumor location were also similar. The major hepatectomy and hemihepatectomy, which were required in both the groups, were also similar. It was 53% versus 55%. There was no difference in the post-operative complication rate except for the operating time, which was more in the laparoscopic anatomical hepatectomy. And the R0 resection rates were also similar in both the groups. With a median follow-up of 72 months, the 1-year and 5-year and 1-year, 3-year and 5-year overall survival was clinically better in laparoscopic anatomical hepatic resection, although the statistical significance could not be reached. The p-value was 0.05. But when the disease-free survival was compared, there was statistical significance also, and there was obvious clinical difference in 1-year and 3-year disease-free survival. The other findings which they could present was the presence of lymphovascular invasions and satellite lesions were similar in the both groups, and R0 resection was also similar, but the mean surgical margins were significantly more in laparoscopic anatomical hepatic resection. The overall recurrence and intrahepatic recurrence was significantly more in laparoscopic non-anatomical resection. In the presence of microvascular invasion, which was a retrospective analysis after the biopsy, the laparoscopic anatomical resection fared better in terms of disease-free survival. In the present study, although it did not confer a obvious overall survival benefit because the statistical significance could not be reached, but there was definite clinical betterment in terms of laparoscopic anatomical resection. Although the OR time was more in anatomical resection, it increased the disease-free survival, it lowered the intrahepatic ipsilateral recurrence, and it had a comparable complication with the non-anatomical resection. The limitation was that the average tumor size which was chosen was less than 5 centimeters, and it was a single center study. Another study from Italy, which was a retrospective study, it showed a 3-year overall survival which was better in patients who underwent a laparoscopic anatomical resection, and they included all the tumors which were around 5 to 10 centimeters. So likely they had more microvascular invasions, that is why anatomical resection was better in those patients. So we can conclude that laparoscopic anatomical resection is recommended for selected group of hepatocellular carcinomas. Coming to pancreas, It was a big trial, the neoadjuvant chemoradiotherapy versus upfront surgery for resectable and borderline resectable pancreatic cancer, the PREOPANC trial, and the long-term outcomes were published in 2022. Again in Journal of Clinical Oncology with an impact factor of 44. It was a multi-center phase 3 prospective RCT including 16 groups in Netherlands, and the aim was to show the benefit of neoadjuvant CRT over upfront surgery in resectable versus borderline resectable disease. Initially, the PREOPANC trial, which was published earlier, failed to demonstrate a clear benefit of the neoadjuvant therapy. The inclusion criteria was pathological confirmed resectable or borderline resectable pancreatic cancer. Broadly, the resectable cancers were those with SMV or portal vein involvement less than 90 degrees, and borderline resectable were those with SMV and portal vein involvement from 90 to 270, or SMA and CHA involvement less than 90 degrees. WHO performance status in the inclusion group was 0 to 1, and there was no restrictions on CA99 level. The exclusion criteria was smaller tumors without vascular contact were excluded from the study. 1:1 randomization were there. 3 cycles of gemcitabine with 36 gray of radiotherapy in the second cycle was used in the neoadjuvant group. All the patients received adjuvant therapy, 4 cycles of gemcitabine in neoadjuvant group and 6 cycles in upfront surgery group in the post-operative period. The primary endpoint was overall survival in intention to treat analysis, while the secondary endpoints were disease-free survival, R0 resection, serious adverse events and complications. The sample size which was calculated was 244. They randomized around 248 patients, and finally the intention to treat analysis was possible in 119 patients in the group which received the neoadjuvant therapy, and 127 in those who underwent upfront surgery. So the baseline characteristics were similar in both the groups. The marked difference was the p-value was significant in patients who underwent who got the neoadjuvant therapy in terms of patients who underwent surgical exploration. So it was more possible in the upfront surgery group, but the R0 section was definitely better in the neoadjuvant therapy group. The tumor size was significantly low, and the number of nodes involved were significantly low in the patients who underwent neoadjuvant therapy. Even the R0 section was much better in patients who underwent neoadjuvant therapy. And on coming to the survival outcome, the median overall survival was 15.7 months versus 14.3 months in the neoadjuvant chemoradiotherapy group with a p-value of 0.025. And when we compare the survival estimates at 3 years and 5 years, there was a marked difference in the survival estimates at 3 years and 5 years in the neoadjuvant therapy group. Again, if we look at the forest plot,
time is up. Can you show the last one, yes, the conclusion one?
So the median survival, although the median survival difference was only 1.4 months, which is suboptimal, but the 3-year and 5-year survival difference was 7.2% and 14%. The limitation of this study was, again, it used a single agent, which was probably related to high rate of progression in the NACRT group in the early period. Presently, combination chemotherapy, that is gemcitabine, capecitabine and FOLFIRINOX is considered to be the standard of treatment. The PREOPANC 2 trial, which is coming up, will give us better answers in these terms. Thank you.
Thank you, Dr. Rahul. Because of the shortage of time, one question or one comment is just allowed.
Dr. Rahul, my question is with regards to the previous trial, the HCC randomized trial, yes, anatomical versus non-anatomical. So one of the slides shows that the hemihepatectomy rates were similar between the two groups. Yes, so that is difficult to understand because the basic idea behind non-anatomical is for basically parenchymal preservation, and a lot of non-randomized studies have shown no difference. So how could the two groups, the anatomical versus non-anatomical, have the same hemihepatectomy rates?
Sir, non-anatomically also they could resect more than 3 segments, or more than 4 segments. So exactly it was not a hemihepatectomy, but it was near a hemihepatectomy. So they included the area which was resected. So they thought that if it is whole of the right lobe is almost resected, they considered it as hemihepatectomy even in the non-anatomical group.
Because then there must be a difference in the tumor sizes, because if a non-anatomical resection involves more than 3 segments and it's nearly hemihepatectomy, then there should be a significant size in the size of the tumors between the two groups. So that was my
So the tumor size was not different, but maybe that the vascular structures were close to the tumor. So hemiectomy may be the only answer to that area. So if the tumor is involving the, say, the right portal vein, then right portal vein has to be resected whether we go by anatomical resection or non-anatomical resection. So the intention was to do non-anatomical, but they landed up in doing a hemiectomy in those cases.
Dr. Rahul, in your first paper, this biliary cancer, both cholangiocarcinoma and gallbladder cancer are included.
Yes, sir.
But do you think that both are different and there should be studied, particularly in India, we have lots of gallbladder cancer. So capecitabine, what is being used in their study, we can also, it can be done and then it will give a better information to us.
So I think capecitabine as a part of adjuvant or neoadjuvant therapy in gallbladder cancer is also becoming a standard nowadays, and it is all based on BILCAP trial only. And even in our institute, we are using capecitabine as an adjuvant therapy in gallbladder cancers post surgery.
So thank you, Dr. Rahul.